Good afternoon, everyone. Good night, those friends in Europe. It's almost 10 o'clock now. This part of the symposium, we're going to talk about post-thyroidectomy, radioactive iodine imaging and ablation. This is one of the most controversial topics. Most of us, as we spoke earlier, avoid discussions because these discussions usually never end. But I'll try to give you my point, my position on these two particular topics. I always like to start with definitions. Definitions set the standards for me. Radioactive iodine ablation, surgical total thyroidectomy is never a complete thyroidectomy in the most strict sense. Even when it's done by the most outstanding surgeons in the most meticulous extracapsular technique used, there's always some amount of remnant left behind. And radioactive iodine ablation, what I call as beta knife, completes total thyroidectomy. Total thyroidectomy with radioactive iodine ablation becomes complete thyroidectomy. These are my terms and definitions. Remnant ablation refers very specifically the use of iodine 131 to destroy postoperatively residual benign thyroid tissue, and that is for the purposes of facilitating the initial staging and follow-up studies in the future. What do we have? What tools we have for follow-up and staging? We have imaging, we have thyroglobulin. When you get rid of the functioning thyroid, normal thyroid tissue, thyroglobulin, as specific as it is, it becomes more sensitive and more specific. More specific meaning now you know that any thyroglobulin level would reflect after achieving a below expected level thyroglobulin, a recurrent sign. Sensitivity is dependent on tumor differentiation, TSH, thyroglobulin antibodies. Dr. Giovanella gave an excellent talk on this particular topic. Nothing further needs to be said. How does it help in radioactive iodine imaging? It clears the atypical and ambiguous looking findings on radioactive iodine imaging. It facilitates the follow-up image interpretations. And we'll get to that in a little while. It improves sensitivity for extent of disease evaluation for radioactive iodine disease. It also helps ultrasound because it has the potential to remove structural artifacts as well. When it comes to the issues associated with ablation activity debate is not resolved. 30 millicurie versus 100 plus millicurie debate still goes on. This is despite two very strong prospective studies published 10 years ago, 2012, by Dr. Malik and Dr. Schlumberger in New England Journal of Medicine. Both studies were published in the same issue, both indicating non-inferiority of 30 millicuries to 100 millicuries. And there is, of course, historically, there is a whole list of other publications, retrospective reports, reporting mixed results, some claiming that 30 is not good enough, some supporting the these two strong prospective clinical trials. Remnant activity determination has nothing to do with the risk stratification, because we hear this over and over again. 30 millicurie is good if you're doing it for low risk patients. You have to use higher for the high risk patients. This is actually not correct. Remnant ablation is done to remove normal thyroid tissue. The one and only reason is eliminating the normal thyroid tissue, and it has nothing to do with the risk stratification. One could, of course, argue that this is more important in the high-risk patients because they need closer follow-up. In reality, the activity to be used for ablation purposes is totally linked to radiation absorbed dose. Radiation absorbed dose is strongly related, linked to the remnant volume and kinetics. Ablation success is dependent on absorbed dose. Absorbed dose is cumulated activity times S value. This is a standard dosimetric expression. The first concept in terms of rad dose to remnant was suggested in 1962 by Gulec. At the time, they were doing radiation lobectomies using radioactive iodine. This original study suggested 50,000 rads. Then Hurley and Becker in 1982 suggested 100,000 rads. And Maxson in 1992 suggested 30,000 rads. This is the most commonly quoted number now. These numbers are very difficult to completely rely on because remnant volume and kinetics are highly variable. Remnant volume determination is imprecise. An error of plus and minus half a gram could change the estimate, dose estimate, by 100%. And in all these studies, early studies, the way the dosimetric numbers were obtained was nuclear medicine physician just talking to the surgeon and surgeon providing a guesstimate as to how much tissue he left behind. Half a gram error is inevitable. Therefore, these numbers have a more than 50% plus and minus change. That makes the dosimetric approach for remnant ablation quite challenging. Now, remnant volumes are inconsistent, particularly in community settings. It's one thing if you're having total thyroidectomies done at Memorial Sloan Kettering by my good friends, Dr. Shah and Dr. Shah, consistently, most meticulously, most outstandingly performing a total thyroidectomy versus in a community with most of the operations being done by general surgeons. There is a wide range of remnant volumes. Last but not the least, the radioactive iodine kinetics clearance from the remnants are also underappreciated, typically not determined, and never spoken. But that is also an important factor. Low activity ablation equivalency, or non-inferiority, is due to the relatively consistent remnant volume in academic centers. I think this is an important point to make. This is the first report by Dr. Beer-Woltes. This is actually, this was published in Journal of Nuclear Medicine in '84. He has this phenomenal book that was published in 1957, giving all the nuts and bolts of how to perform radioactive iodine treatment in thyroid cancer. This particular study is reporting the experience, Beer-Woltes' experience in University of Michigan, Ann Arbor, between the years of 1947 and '84, since the inception of the radioactive iodine treatment concept in cancer. And it says in this paper that 40% of the patients ultimately required the second treatment with 100 millicuries when they received 30 millicurie low activity treatment. Overall, his point was that 100 plus millicurie was better. Then there's, again, as I said, multiple papers, hundreds of papers claiming otherwise. It's a never-ending debate. This debate dragged the issue to 2012, and back-to-back, these two papers were published in New England Journal of Medicine. Dr. Malik from London reporting non-inferiority of 30 millicurie treatment to 100 millicurie treatment, and Dr. Schlumberger likewise reporting the same in the same issue of New England Journal of Medicine. These two papers can, the discussion of these two papers can take another whole hour. I just want to tell my point. Both papers refer the treatment as dose, which in fact is not the dose, but administered activity. And I have a categorical objection to low dose versus high dose references made, because dose is not the same with millicurie. In fact, there is no linear correlation between radiation absorbed dose and administered activity. Years later, we did a kinetic study using I-124 PET-CT in a limited number of patients. I believe we had 16 patients in this pilot study. We had quite interesting findings. Then this small group of patients, the numbers, remnant-related numbers were very, very different from one patient to another. Maximum total remnant activity, microcurie activity, ranged from 1.2 to 216. Functional total remnant volume ranged from 1 to 60. Activity per milliliter total remnant volume ranged from 0.04 to 11.2. And total remnant cumulated activity ranged from 68 to 12,750. The minimum and maximum range were quite different. In fact, most patients even had significant differences between right lobe remnants and left lobe, right and left lobe remnants. I have to remind again, these numbers, these results were obtained from a community setting where these operations were done by different surgeons referred for radioactive iodine ablation. Everything boils down to, when it comes to remnant ablation, any suggestion, any rule that is applicable to community setting, that is applicable to a setting that surgical procedures, surgical remnants show significant variation, one has to be very careful making strong suggestions. What works in our institution is, of course, we do not do individual remnant volume assessments. Instead, and I'll tell you why I do what I do later again, we treat everybody with remnant, we do remnant ablation on every post-surgical patients just to achieve the goal of removing normal thyroid remnant. No radioactive iodine ablation has been advocated in low-risk patients. No radioactive iodine. Radioactive iodine ablation is indicated when total thyroidectomy is indicated. If the surgeon is taking the risk to remove a whole thyroid gland, risking recurrent laryngeal nerve, parathyroids, the surgical risk is way much more than nuclear medicine radioactive iodine risk. Of course, we're aware of all the risks. This is not drinking water, but there is also a tendency to over-exaggerate the potential side effects of radioactive iodine, especially when you compare this to the surgical risks. You can easily silence a young 24-year-old woman if you have a recurrent laryngeal nerve injury when the surgery, especially when it's done for no justifiable reason. 29 millicurie activity has been advocated for low-risk patients. Risk category has no bearing on activity determination. It has bearing on whether to do ablation or no ablation. The question always is ablate or not to ablate, not how much to give. How much to give has to do with your institutional experience, your anticipation or calculation or measurement of the remnant volume. When a preoperative decision to perform a total thyroidectomy is made, radioactive iodine ablation should be performed. This is our stand in our institution in Miami. When we come to the pre-ablation radioactive iodine imaging with I-131, this is another highly controversial issue, but overall experience in the world since we started using radioactive iodine in 1940 for the cancer, thyroid cancer in 1943, is that lower activities have lower sensitivities. 1 millicurie on the left side is not showing any lesions, whereas 100 millicurie demonstrating metastatic disease. This is diffuse liver uptake indicating there's functional thyroid tissue. Pre-ablation diagnostic radioactive iodine imaging is subtheranostic, more so with BRAF tumors, BRAF-like tumors, and BRAF tumors are the tumors that go to the lymph nodes. RAS tumors rarely ever go to the lymph nodes. If they ever, they typically go to distant metastatic sites. There are other mutations that behave either BRAF-like or RAS-like. They can be associated with cervical nodal metastases. Small volume nodal disease is below the detection sensitivity. Here's another example of a lesion disclosed after a higher activity treatment imaged post-treatment setting. Does the imaging modality matter? It does matter. As Dr. Van Nossen, not all the imaging techniques are created equal, not all the scans are created equal. Here's an I-124 imaging compared to I-131 imaging. It clearly is superior on a bi-lesion basis. It does offer improved spatial resolution, and it also offers improved detection sensitivity. But this doesn't necessarily translate into specificity when it comes to the neck. Here's a patient from our series. One could easily call these distinct focal areas of uptake as nodal metastases, but these are proven to be remnant tissue, not metastatic disease. Again, improved detection sensitivity and spatial resolution does not translate into diagnostic accuracy, which is a different issue. Wonderful paper by Dr. Van Nostrand. Not all radioiodine images are performed equally. Not all the areas of paramedian focal uptake are nodal metastases. So, and I'm going to give you back-to-back surgical images. The rest of my presentation will be actually a surgical anatomy lecture. This is a publication from our good friend, Dr. Anka Avram. There is a non-iodine avid superior mediastinal lesion, and this long arrow is clearly a remnant, as she mentions in the publication. These lesions are also remnant tissue, not necessarily metastatic lesions. This is a beautiful picture, again, showing that improved detection sensitivity, improved spatial resolution does not necessarily translate one-to-one to diagnostic accuracy. In surgery, there are areas that thyroid surgery is about recurrent laryngeal nerve and parathyroid glands, more so recurrent laryngeal nerve. We do everything in our power to protect the nerve, to see the nerve, to protect the nerve, and to preserve the nerve. And the thyroid tissue, especially certain specific anatomic locations, have very strong intimacy, close intimacy with the nerve. These areas are superior poles, zucocondyle tubercle, and right at the sites of parathyroid glands. At the superior pole, we deal with external branch of the laryngeal nerve, and it's very close to the upper pole. Surgeons typically transect the upper pole below although they can go up to the vascular structures up here, superior pole vessels, they prefer not to go too high to protect external branch of the recurrent laryngeal nerve, course of which is highly variable, and in a significant number of the patients, it is right at the superior pole. That's why surgeons tend to leave a little cap in the superior pole. I'm going to skip this video. This video shows how maybe I'll just show it. The clamp was placed in the upper pole, and the transection is done just below the pole. Between the clamp and the heat device, the harmonic scalpel, there is a thyroid tissue that will show up as a focal uptake in the upper pole, which would just look like metastatic nodal disease. Here are two patients, two scans with focal uptake, paramedian focal uptake. These are remnants, not nodal metastases. It's very easy to confuse them. And as a nuclear medicine physician, you would be wrong if you reported these not suspicious for nodal metastases, because they are suspicious. But this also tells you that we are very prone to call non-metastatic lesions as metastatic lesions. Parathyroid gland, how intimately involved with the capsule to preserve the vascularity of the parathyroid, will leave a little rim of thyroid tissue right underneath. Here is the Zucker condyle. No, I'm sorry. This is the ligament of Berry. Ligament of Berry is where the recurrent laryngeal nerve dives into the larynx. As I always tell to my residents, a little bit of thyroid tissue is preferable on the recurrent laryngeal nerve than a little bit of recurrent laryngeal nerve on the thyroid tissue. To avoid any injury, surgeons may leave a sliver of normal thyroid tissue right at the ligament of Berry. This is the Zucker condyle tubercle, which right behind of which runs the recurrent laryngeal nerve, inferior laryngeal nerve. This is another area that surgeons tend to leave a little piece. This paper came in 2015. This is a very good paper, not so well-known paper. 140 patients who had total thyroidectomies performed at Memorial Sloan Kettering by the best surgeons, and Harvard by the best surgeons. This summarizes everything I just told you, the remnant activities and sites in the critical surgical anatomical areas. This report clearly indicates that even in the best hands, there is significant degree. Significant is not in the sense of surgical, but as far as diagnostic accuracy of a SPECT CT, they are very significant. 93% of diagnostic planar imaging shows these artifacts, or remnants, I should say, not artifacts, and 99% post-treatment scan SPECT CT shows these remnants. This is one of our patient series. This is clearly a remnant. Everyone can call this a remnant, and most everybody would call this a lymph node. This is also a high riding upper pole, not nodal metastases. We published this in 2017. To further highlight, prove our point, we designed a F.A.C.N.M study. This F.A.C.N.M study is actually a best case scenario. We didn't use any background activity. We placed the sources very close to the F.A.C.N.M material. It was a months-long study. The endpoint was minimum detectable activity with, under the best case scenario, was 0.15 microcurie. That's 0.5 microcurie activity when you translate into clinical situations. If it's a remnant with a theranostic power of 100%, because it's the normal thyroid physiology. The smallest size you can detect is 0.4 centimeters. But if you're dealing with a RES-like tumor, which typically has 40% of the theranostic power of a remnant, that number is 0.5 centimeters, and that number goes up to 1.2 centimeters if you're dealing with a BRAF associated nodal metastases with 3% of normal thyroid remnant uptake. To the minimum detectable activity would be visible in a 1.2 centimeter lesion. Therefore, and these lesions are in the site of an ultrasound. Any such activity detection on SPECT CT in a BRAF-like nodal metastases should be easily detectable on ultrasound. And the last word on imaging, pre-ablation imaging, radioactive iodine imaging, is the clinical value of pre-ablation radioactive imaging is limited. Low theranostic power because of the attenuated radioiodine avidity, as I call radioactive iodine indifference. This is more prominent with BRAF-like tumors. And small volume nodal diseases below the detection sensitivity for diagnostic activities we use. Focal remnants can be misinterpreted as nodal disease, falsely upstage patient potentially. And there are logistical issues if you're using common human TSH for the purposes of ablation. One thing that is indispensable is post-ablation imaging. It has to be done. And if you're using, say, 100 millicuries, and if you don't see any known metastatic activity, that is a clear indication of a radioactive iodine refractory disease. This is where I intended to stop my talk, but graciously, Dr. Larson donated 10 minutes. So I'd like to paper that was published last week to ablate or not to ablate. This came out from Institute in Paris, Institute Gustave Rousseau, a very famous and credible oncology institute, perhaps the most credible one in the country. Dr. Lebuleux and Dr. Schlumberger, thyroidectomy without radioactive iodine in patients low-risk thyroid cancer. This has been Dr. Schlumberger's quest since early years in his career. He actually published a paper with Dr. Robbins at Memorial Sloan Kettering. He was suggesting back in 2005, almost 20 years ago, that radioactive iodine ablation can be omitted in low-risk patients. The study is very straightforward, very cleverly done. One arm received surgical treatment, no ablation. The other arm had iodine ablation with 30 millicuries. And the non-inferiority was concluded based on the overall events in two arms were the same at 3 years. It was 4%. And events as defined by structural or functional diagnostic modalities, 3 versus 5, by thyroglobulin, 12 versus 11. These were statistically insignificant. Conclusion was, okay, we do not need to give radioactive iodine ablation. I think that was a quick call. I had the chance to read the paper in detail, and I have noticed few details that I'd like to share with you. And at the end of the day, I'd like to discuss with all the faculty and all the participants. This is the inclusion criteria to the study. They are very clear and straightforward. What's interesting is not the inclusion criteria, but the exclusion criteria as listed under non-inclusion criteria. Non-inclusion criteria number 1 was patients having undergone less than a total thyroidectomy. And this was measured by doing a formal ultrasound, and the ultrasound was negative, detecting any remnant or any abnormal proof requiring lymph node findings. And the second one was abnormal postoperative neck ultrasound of the lateral lymph node compartments. So that was all taken out. And then the last one was patients previously treated with radioactive iodine, and also previously who underwent a total body scan with radioactive iodine. This was probably placed to avoid any contamination from stunning perspective. But these three things, exclusion of these three things, that clears the data. These are the reasons why we do the radioactive iodine ablation. Now, this is a mixed bag of post-thyroidectomy, near thyroidectomy, near total thyroidectomy, near subtotal thyroidectomy package. The height of these bars indicate the volume of the remnant. It's a mixed bag. Some remnant volumes are small, some are very big. The design, the smart design of this study, what it did, first of all, well, this is what we accomplish by giving radioactive iodine ablation. All these uneven remnant presentations, by giving radioactive iodine ablation, they are all leveled to ideally a thyroglobulin level of 0.1, undetectable by ultrasound, undetectable by a radioactive iodine scan. So this is the clean slate we like to achieve to follow the patients more comfortably for them and for the following physician. This data optimization, I call, in the study, what was done, first the ultrasound was done, and ultrasound picked any potential abnormal ones, and they removed the ultrasound detected abnormalities, removed from the picture. Then they said, we don't want radioactive iodine scan part of anything. And then the comparison of events were made when it comes to thyroglobulin. The not ablated patients had a different standard from ablated patients. A thyroglobulin of 1 was required for ablated patients. A thyroglobulin of 5 was required for non-ablated patients, which increases the threshold for events. And with performing all these, by removing all the factors, all the reasons we do the ablation for, in your ideal data set, in your ideal patient population, the study concludes that ablation versus no ablation, the events are the same. The ideal study should have been done without excluding different size and shape remnants, without excluding patients who had baseline scans. They should have treated one group of patients with ablation, the other side with no ablation, and compare the events in these two patient populations. I'd like to discuss this with everyone at the end of the day. So my conclusion is as to post-thyroidectomy radioactive iodine imaging and ablation. Post-thyroidectomy radioactive iodine imaging is sub-theranostic. I don't do that. I don't recommend that. Those friends doing it, they have their reasons to do it. And if it's working for them, they will continue to do what they do. Radioactive iodine ablation is indicated, in my opinion, when total thyroidectomy is intended, because that's the only way to remove all the functional thyroid tissue. Surgical thyroidectomy is in the most strict sense never a complete thyroidectomy. Thank you very much. I think